And we're rolling.
Perfect. So I'll just start sharing my screen then, and we'll get started. All right. So today we're going to have a look at Cardiovascular Anatomy 2. We already covered Cardiovascular Anatomy 1 last week, which is sort of to do with thorax mainly rather than the actual heart and the cardiovascular system. Today is going to be more focused on the actual heart itself, the organ, and the vessels coming out of it. Right. So it's going to be a lot more content as opposed to what you've previously done, but it's also going to be combining a lot of stuff you've already learned. Like you've already learned a bit about the blood flow in physiology. You also learned a little bit about, I guess, the actual electrical circuitry at some point as well in physiology. So we're going to be combining all of that, but then with the actual anatomy of it as well. And if you're wondering why I'm wearing this funky beanie on my head, it's because, yeah, I tried to cut my hair at home. So I think you're better off with the beanie on. All right, let's have a look at the topic today. So a quick tip for cardiovascular anatomy. I know it's very, very confusing in terms of all these different terms and different names for parts of the heart. And often those names, they have synonyms and alternate names that sound just as confusing. So what I'd recommend is when you're starting off learning about cardiovascular anatomy, take the very, very basic big picture, the clinically relevant bit that's going to help you understand the clinical aspect of everything, to be able to understand how the clinical skills side of the thing works. And then once you understand that very big picture idea, break it down into like smaller details, and then bring in all the complicated terminology that will help you actually, do well in the tutorial and examination part of things. So I'd say that's the approach that I would recommend for cardiovascular, because it's just got a lot more content than other sections. And accordingly, these slides have kind of been made that way. And we've sort of kept it simple and high yield with, I guess, progression so that you can slowly get towards learning the more detailed aspects of some of the anatomy. So I'll show you what that means in a second, but we'll start off with some very important topics when it comes to the cardiovascular system, being first of all, blood flow. It's very important to understand how blood is flowing through the cardiovascular system, being, through the heart and then out through the body and the lungs, right? So you've got two circulations in your body, the pulmonary circulation and the systemic circulation, both of which you've already been introduced to in the past. The pulmonary circulation is all about passing blood through your lungs and then oxygenating it. And systemic circulation is all about passing blood to parts of your body where it's going to be used up. The oxygen is going to be used up for metabolic demand, right? But it's important to understand how that blood actually flows to the chambers of the heart, because there's a number of valves there as well you want to keep in mind and also have to memorize for the exam and the clinical aspect for auscultating later on as well. So it's important to understand that when we have blood that's deoxygenated from the body, it enters our right atrium up top here. Then it passes through the tricuspid valve, then the right ventricle, then the pulmonary valve, and out to the lungs. Okay. And then it goes to the lungs and it gets oxygenated up. And then it goes to the left atrium, and then through the mitral valve, and then the aortic valve, and then out to the body. So those are the sort of orders and the chambers that you can expect to see when discussing about the heart. Now, of course, the heart is a 3D structure, so it doesn't actually look like this 4-chamber arrangement when you put it into the body. So it looks something more like this on the right over here. I think this diagram is really good to understand how those chambers are actually oriented in 3D. So that's going to be your first progression. Learn this 2-dimensional aspect of how blood flows. Then think about how that actually is anatomically oriented in terms of where those chambers are located anteriorly and posteriorly, medially and laterally. And then you can put that into the context of actually putting it alongside other structures nearby, like the lungs and the diaphragm below it. So that, an example of that would be on the next slide here, where I think over here you can see the borders and how things relate to the heart. We'll come to that in a second. But the important part is just, first of all, learning blood flow through the heart and the lungs. The next step from there then is to learn about the valves, right, that the blood is going to be flowing through in the heart. And again, there's a lot of confusing terms here with 4 different names you have to learn and different structures of those valves as well. But I think it's very easy to just sort of separate it into, I guess, 2 categories of valves. There's atrioventricular, which will normally be seen referred to all the time. And then you've also got the valves that are going to actually allow blood to leave out via the great vessels, okay? So semilunar and atrioventricular, which is the sort of common way that they're separated. And when it comes to actually memorizing the valves themselves and memorizing which valves blood is flowing through, a good mnemonic you could be using is something like toilet paper my apartment, which tells you that the first valve you're going to encounter when you're entering the right atrium and trying to go into the right ventricle is tricuspid, then pulmonary out from the right ventricle, and then mitral going into the left ventricle from the left atrium, and then aortic going out of the left ventricle. But again, that's something you can sort of tailor to your own purposes. And then the last thing you have to remember as well in terms of the valve structure is that they all generally have 3 leaflets. So that's sort of the individual parts of the valves that are going to open up to let blood flow through. But there's also a bit of a peculiarity here where the actual mitral valve only has 2 leaflets. And the way that I remember it is the only word there with 2 syllables in it. And of course, you can also get into more detail over here as well, talking about the different names of the individual valves. Like there's anterior, posterior, medial, lateral parts of the valves. But we're not going to be going into that today. That's something you'll probably be covering in specimens and yeah, probably in specimens more, but it's not going to be high yield at all for exams. We'll come back to that later though for auscultating when we're looking at the clinical aspect of it. So next up, we have the great vessel. So we learned about the actual inner structure of the heart, talking about blood flowing through the heart, as well as the valves of the heart. But the next thing we're going to be talking about is how the blood is going to be exiting the heart through these big vessels, which we accordingly call the great vessels. And there's big vessels that allow blood to enter the right atrium and enter the left atrium. And also big vessels that allow blood to exit via the aorta and the pulmonary trunk, right? So we're going to be sort of just orienting ourselves to those, I guess, those structures. But the most important part to understand, I think, from all of this is that the pulmonary trunk here actually goes under the aortic arch, which is kind of confusing to wrap your head around because the aorta starts sort of on the left, but then it sort of curves around and makes its way out over the pulmonary trunk and then goes down. That's probably the only anatomical relationship that I want to really emphasize here. So just keep that in mind. That's why it's called the aortic arch, because it's arching over the pulmonary trunk structure, right? And on the right here, you also have the borders of the heart. So you can look at borders in 2 ways. Normally, you'll look at it in this bottom sort of description over here, but we'll go over both of them. The first way you can look at the borders of the heart is think about the heart as the actual 3D structure, and then look at the faces of the heart. So the difference, the sort of the anterior face, the posterior face, which you call the anterior surface and the base and things like that. And then look at structures that it contacts on those sides. So on either side of the heart, you obviously have the lungs because the heart is situated between the lungs. So you have the right pulmonary surface over here and the left pulmonary surface. And then probably a very, very important part that you want to keep in mind is that your heart is resting above the diaphragm. So the diaphragm is just below it and it's just sitting on top of it. So you want to keep that in mind as well. And yeah, that's sort of the main things that you want to keep in mind in terms of relationships of stuff around the heart. And in terms of the borders as well, I think I've put something down there in the notes for you to have a look at. But yeah, that's sort of the main things that you want to keep in mind. Next, we're going to come to the coronary vessels. I think we're already going to be covering this with James's topic later on when it comes to coronary artery disease. But we're going to look at it in more of an anatomical sense. So with the coronary vessels, it's all about the heart pumping oxygenated blood to supply itself, because we know that the heart is going to be pumping around oxygenated blood to the rest of the body to be able to meet the metabolic demands. But the heart itself is also a muscle that's going to be contracting and pushing blood all around the body, which means the heart itself also needs to receive some oxygen. And therefore, while it's pumping blood out to the rest of the body, it's also pumping blood to itself. And that's achieved via this coronary circulation. And you can see over here on the right exactly how the blood goes from the aorta and ends up in the coronary circulation. So the way it does it is through those valves. It gets caught in the spaces formed between the valve leaflets, and then during relaxation, it can actually fill up and enter the coronary vessels. And then when it's contracted, however, and blood is rushing out, those leaflets open up and therefore blood can't actually get through the coronary circulation. So it's only able to achieve this during ventricular relaxation, not during the contraction phase. So again, with coronary circulation, you can get very bogged down in details and talk about the individual branches. And there's quite a lot of names and branches, but there's only a couple of ones that you really want to remember. And that's the the right coronary artery, left coronary artery. Posterior descending is probably one of the most important ones to remember. And we'll take a look at all three of those as well on the right over here. So on the right, I've drawn kind of a simple schematic showing these coronary arteries and the branches. And you can notice that there's actually two schematics here. There's a right dominant schematic and a left dominant schematic. And that's because in reality, there's two different configurations that you can have with your coronary vessels. It can either be in the right dominant configuration, and we'll talk about what that means in a second, or left dominant. Now, with right dominant configurations, what that means is that the posterior descending artery is coming off the right coronary artery. So just to orient you a bit to what that means, first of all, we have our aorta here, right? And then coming off our aorta, we immediately have your right and left coronary arteries, right? We can see that straight away. They're going to be the first branches that come off the aorta and the first branches of the coronary system. And then from there, we have further branching going on, right? On the left, we have a circumflex artery, which is kind of important to remember because it's going to wrap around and help supply the back of the heart as well, the posterior surface. But we also have marginal arteries from up front that supply more of the ventricular side of the heart over here. And you also have a left anterior descending artery, which you can, I think, see maybe not on this diagram on the left here, but I've labeled it in here anyways. But yeah, those are sort of the main branches that you want to keep in mind. But probably the most important one to learn about is the posterior descending artery, which is kind of not shown as well here because it looks like it's anterior, but in reality, it's a posterior artery. So you can see it probably better over here if they've labeled it, which I don't think. Oh, there it is, posterior interventricular artery, which I think is synonymous with posterior descending artery, because it's going to be an artery supplying the interventricular septum of the heart. And so this artery can either connect up to the coronaries on the right or connect up to the coronaries on the left. And you can see that being highlighted here on a diagram. Now, what's the consequence of that? If you have a right dominant configuration, it means that most of that heart is being supplied by the right coronary artery. If you have a left dominant configuration, it means that most of the heart is being supplied by the left coronary artery. And we'll see the consequences of that later on when it comes to actual infarcts and when it comes to ischemia, how blockages of either the right or the left are going to affect the heart. But again, if you have any questions as well along the way, feel free to pause them in the chat. Otherwise, we'll leave this here and come back to it when we talk about actual infarcts. So coronary vessels, venous drainage. This stuff is, again, very, very low yield, but I've just included it for completeness. I think the only thing you should probably keep in mind is, first of all, where the coronary venous system originates. It sort of drains into the right atrium via this large channel here called the coronary sinus. And I think the first time I heard this, I was very confused because you hear about the sinoatrial node, you hear about sinus this, sinus that, sinuses are everywhere, right? But sinus is just a very, very basic term that refers to a chamber, or like, it usually refers to an air-filled chamber, but it can also be fluid-filled over here with venous blood, right? So it's just a simple word for a chamber. And in this case, it's a chamber in the coronary system, in the venous system, that's going to drain into the right atrium, okay? From here, probably the most important branches you want to remember are just the most proximal, I guess, which is the great cardiac vein, and the small cardiac vein. And they're really easy to remember because you know that the left side of the heart is the more prominent side where there's the bulk of the muscle, right? So you can remember that left side as being greater for that reason, and therefore that branch going to the left side as being the great cardiac vein. And then the opposite one being the small cardiac vein. And you can see them on the diagrams here as well, so that you can appreciate them in 3D. Okay, now we probably come to one of the more important aspects as opposed to venous drainage. Pericardial layers are definitely important to remember because they can be very commonly tested on and asked about. So pericardial layers refers to the layers that surround the heart. So the heart is wrapped in 3 layers of serous membrane or pericardium. And those 3 layers around the heart we call pericardium because they are around the heart. Now, those layers are the visceral layer, which is epicardium. We can sometimes separate that from the pericardium, but it can also be merged together with it. So you have the visceral layer that's stuck around the viscera, the actual organ itself, called the epicardium. You have the parietal layer, which is sort of one layer out. and then the fibrous layer, which is another layer out as well. And we talked about the embryology of how that formed a while back. So if you're a bit confused about that, I'd recommend going back to that lecture. But we talked about how the folding of the folding of the pleura of the heart and also the pericardium form these three different layers. Okay, so another thing to keep in mind as well is that with all of these structures, some of them have pain innervation and some of them don't. So for example, with the parietal or fibrous layer of the pericardium, so that's the outermost one and the one further in from that, they're both innervated by the phrenic nerve and they have pain sensation. So if you cut any of those two, you're going to experience pain, right? Because there's no susceptive fibers there. However, the visceral layer and the organ itself, right, they don't actually have pain sensation, and that sort of makes sense because we weren't sort of we didn't sort of evolve to be able to detect pain inside of our body, because it's very we sort of developed more to detect pain that's coming from our external environment and that's contacting our, I guess, peripheries. So that's why our internal organs and systems don't really have those receptive fibers. And so if you were to actually cut the heart itself, the action of cutting the heart, if you're removing all the other layers, if you just cut the heart itself, the organ, that wouldn't actually cause any direct pain, but you'd probably get pain from the effects that stem from it, like, you know, not being able to pump out blood as much, and then that causing ischemia, and then that causing pain in surrounding tissue. So just keep in mind that parietal layers do have phrenic nerve innervation and therefore pain sensation, whereas visceral layers and the organ itself lack that. And so if you cut those, there's not going to be direct pain from that. Okay. And then the last bit to keep in mind here as well, which is shown on this diagram, is that the pericardium of the heart is continuous with the diaphragm's anatomy, in that the diaphragm central tendon is continuous with the fibrous layer of the pericardium. And we'll be coming back to that as well. We'll talk about cardiac tamponade and pericardial effusion. Okay, now we already had a look at this slide previously with the innervation of the heart, but it's also important to keep in mind what it looks like from an anatomical perspective. When it comes to sympathetics, you've got T1, T5. Well, actually, we'll start off maybe with parasympathetics because they're a bit easier to understand. So parasympathetics, you have your vagus nerve, and that starts off in the brainstem, comes down, and then innervates aspects of the heart, like the SA node and the AV node, to help lower the heart rate by lowering the rate at which those pacemaker cells are firing. And that's sort of shown here as well on this diagram in the table. And you also have the sympathetic system. It's a little bit more complex, but in the intermediolateral cell columns, I think that's what it's called, the IMLCCs of the T1, T5 spinal cord nerve roots, you have them coming out, going into the sympathetic chain, and then heading up and coming out from there. Okay, so that's why it's important to keep in mind that even though those nerves are coming out all the way up here, they actually originated down in the T1, T5 region and then came up there and ascended there and then branched out to the heart. And that's sort of shown here as well in the diagram. It's important to keep that in mind for when you're labeling them on diagrams, what they look like. And yeah, I think one thing we also covered as well, which is sort of the physiology aspect, so it's not too fussed about it here, but it's that at rest, your heart has a parasympathetic tone, which is why you maintain a lower heart rate than your SA node is firing without any stimulation. So that's, again, something we covered previously, so you can have a look at that topic and refresh that idea. And another thing to appreciate is actually being able to then take your understanding of the innervation of the heart and look at a diagram where there's sort of a cataract dissection and be able to identify those nerves, which can be kind of tricky because there's a whole bunch and mess of different structures around the heart. The main thing I think is just following the nerves along and then seeing which one's which based on where they're going and where they're coming from, right? So first of all, I think it's quite clear to identify the sympathetic ganglia. You can see on this diagram over here as well, it's been labeled. It's on a diagram, so it's kind of reliable as well in terms of I guess the anatomical locations as well. So you can see that the sympathetic ganglia are sort of these bead-like structures. You can see kind of clearly at the back, just peeking out over there. So you can imagine that somewhere in the T1, T5 region, that are those IMLCCs. They branch off, and then they're going to come in via the cardiac plexus, and innervate the heart, SA node, AV node, and other aspects of the heart, like the muscle, the cardiomyocytes as well. Then you also have this nerve over here, right, which is most likely going to be phrenic because it's innervating the pericardial surface of the heart, and you can see on both sides as well. Yeah, so those are sort of the main things that you want to cover there. And there's also some miscellaneous points over here. I've seen them being covered by previous PSPs, but I don't think they're particularly high yield, except for maybe if you're doing specimens and you want to figure out what these are for the purposes of answering the question specimens. But they're not particularly high yield. So the first one is trabecular carne. And that's basically just referring to the ridges of muscle on the ventricular wall. So if you look in the ventricular wall, you can see that it's not actually a smooth surface. You can see over here that's got kind of a rugged surface, and those ridges that are formed by that rugged surface, we just call them the ventricular, they call them the trabecular carne. And I think the purpose of having that rugged surface was to prevent suction, because if you had a flat surface there and you're pumping, there'll be some suction that prevents the blood from completely going out properly. But it's kind of a minor point. And just remember that what it is and where it is as well, I think, is all you have to know. Chordae tendineae refer to the actual connective tissue that attaches the leaflets of those valves to the papillary muscles. So one thing that we talked about was those valves. We didn't really talk about the microstructure of the valves, probably primarily because it's not that important in terms of, I guess, the clinical aspect. But when we come to the microstructure, the way that the valves, at least the atrioventricular valves work, is that they have these papillary muscles to help keep them shut. And you can have a look online as well, like animations as to how they work. But those papillary muscles help keep them shut. They contract to keep them shut. But then the chordae tendineae are the actual little tendons or connective tissue that connects those papillary muscles to the valves themselves. Kind of like your normal muscles, right? There's an actual muscular bit and then a tendon attaching it to either end of a bone, but in this case, it's going to be the papillary muscles on either side. You also have another sort of anatomical landmark called the triangle of Koch. I'm not sure how to pronounce that, but triangle over there. And you've got three structures that are sort of used to triangulate and locate the SA node. So maybe in specimens, they might ask you to locate those three structures. And then at the top of that triangle, you're going to find the atrioventricular, or it should be the atrioventricular node, not the SA node. But yeah, so there's that there. And you also got the auricle, which is also a minor structure, but you can see it over here on the right and the left surfaces of the heart. There's auricles, or what's called flaps, on either side that can hold excess blood from the atrium, and that's going to be relevant when we talk about things like atrial fibrillation when we have a look at it later on. Okay, so I think I focus primarily with these slides on the clinically relevant parts of them, because they're probably going to be the most important things you want to keep in mind for both, your exams, but also when it comes to actually taking this knowledge and translating into clinical practice. So the first thing we're going to be talking about is heart valve auscultation. You'll probably be talking about this and talking about the different locations. The first thing that you want to keep in mind is that we don't actually auscultate directly over the valves. We auscultate slightly, I guess, in a different location. And the primary reason is that we're trying to hear blood flow coming out of the valves. So we auscultate at a location slightly, I guess, I'd say, I use the word distal there, but slightly ahead of the valve. And that way we can hear the blood coming out of it. And so the auscultation location is different to the anatomical location, also because other structures kind of get in the way. Like, for example, if you look over here, the sternum is right in the way of auscultating these different valves over here. So it's kind of hard to do that with the sternum in place. So we kind of use areas on either side to get a better access of the heart sounds. Now, there are locations that unfortunately you do have to memorize for your cardiovascular exam, but also potentially for the exam as well. And so you have them shown over here. But I think that another useful way you could think about remembering is the apartment is the mnemonic apartment M2245, which again is just another way you can remember it, whatever works for you. But I think one way that I really remembered it was that only one of these locations is on the right side, everything else on the left side, and they're almost all going to be parasternal, except for this single one over here, which is midclavicular. And then there's two here at the second space, intercostal space, one here at the fourth intercostal space, and then one in the fifth intercostal space. And you can think about ways you can memorize that in any way you want. But yeah, as for the heart sounds themselves, we're probably going to be talking about that more in clin skills, but they're not too high yield at this stage. Just know where they're going to be heard for at. Next up, we have, when it comes to heart valves, the actual heart valve defects. So there's stenosis and regurgitation. And these are going to be things you're probably going to be covering in your LOs for anatomy. But main ideas when it comes to those terminologies is that stenosis refers to a hardening, right? Stenosis means hardening. So whenever you hear the word stenosis, just think of something becoming stiffer and hardened. And if your valves become stiffer and hardened, they're not going to be able to open as easily. And what that means is that when blood is trying to push through, only a small amount gets through. So it's going to be the problem you're going to be having here, which is that blood is not able to push through, and a small amount is going to end up in the post chamber, the chamber afterwards. Regurgitation is a similar idea. It's where the valves instead become very weak, which we also call valvular insufficiency. But the valves themselves become very weak. And what that means is that they actually don't close properly. And so when blood goes out, it goes out fine. But then when it tries to stay in the other area, because the valves don't close themselves properly, blood can actually leak back a bit, which we call regurgitation. And that's why you can end up with, in both of these scenarios, not enough blood reaching the next compartment. And you can pick that up on auscultation as a murmur, which is why we learn about auscultation. You can detect stenosis and regurgitation by looking and listening for murmurs. You'll actually hear the specific heart sounds, but we're not going to be going over that. And then you can also think about, if you're having less blood coming out of your heart, that's going to lead to hypoxia of tissue. And therefore, you're going to see those characteristic signs of hypoxia like tiredness, fatigue, maybe a little bit of cyanosis in some areas as well. If there's not blood, if blood is not able to properly oxygenate because of the valvular defect. But we're also going to be having a look in particular at ventricular hypertrophy and talking about anatomically and pathophysiologically how that occurs. So stenosis and regurgitation, when they happen, your heart tries to adapt to it. And one of the ways that it can adapt is hypertrophy, or become bigger to try and contract against that either stiffened valve, or to try and hold more blood when there's regurgitation happening. So we'll explain what that means in a second as well. So over here on this diagram, you can see what I'm referring to with hypertrophy. Whenever you have valvular disease, what can happen is that your heart can respond by undergoing ventricular hypertrophy, which is called a maladaptive response, because sometimes it does, provide a temporary, but because your coronary circulation can't keep up, it's usually going to lead to heart failure. So that's something that we're going to be talking about as well. So we'll talk about it in the context of valve stenosis first. So when it comes to valve stenosis, again, keep in mind and remember what those words mean. Stenosis means hardening, and therefore the valve, if it hardens, it's going to be harder for blood to get through a stiffened valve, which is not opening as easily. So there's going to be less blood exiting a chamber. So there's more blood accumulating in that pre-chamber, right? So that pre-chamber has less blood exiting it. It's going to accumulate more, and there'll be a pressure buildup because all that blood is just staying there, right? And so we call that preload pressure. One thing I think you may go over is that as a result of this preload pressure, you have what's called concentric hypertrophy. So there's two types of hypertrophy here, concentric and eccentric. Concentric refers to adding more sarcomeres within the myocytes in parallel. So you're not actually adding more cells themselves, you're making the cells themselves bigger, but you can make them bigger either along their width or their length. In this case, you're making them bigger along their width and making them thicker, right? And the idea is if you have more muscle mass, you're going to be able to push more forcefully through that stiff valve and therefore really force that blood out of that stiff valve. And that might work to restore some heart function when you have valvular stenosis. But the I guess the downside here is if you're actually increasing all that muscle mass, but you're not actually able to have the same capacity to increase the coronary circulation, you're going to have a very high demand from the cardiomyocytes to be able to contract, but not enough blood going to them to actually support them. And so your cardiomyocytes are going to start having ischemia, potentially even die if there's not enough reaching them. And so you're going to have this situation of long-term heart failure. So on the right over here, you have a similar thing occurring with valvular regurgitation. that's where you have a volume overload in your post chamber. So remember, keep in mind again, regurgitation is where blood is going through, but some of it's leaking back, right? So that's why you got a volume overload in the post chamber. And as a result of that, you have eccentric hypertrophy. And that's a similar thing, except instead of growing along the width, they're growing along the length. And a similar problem here. It's good to some extent. It actually happens in athletes to some extent, but if it happens chronically, it can actually lead to heart failure as well there. And so just keep that in mind. I'm not sure if it's going to be too high yield for your exams, but I just put that in there because it was mentioned as one of the topics for, I think, one of your LOs. Okay, so then over here we have coronary artery disease. This is definitely an important one to keep in mind. So we talked about right dominant and left dominant coronary artery configurations. Now we'll talk about how that's important when it comes to the actual, I guess, clinical aspect of it. So clinically, we talk about the coronary circulation becoming blocked. So that could be anywhere along here. Maybe an emboli comes along, gets lodged, and blocks off, or at least obstructs partially the vessel there. Right, and you can have that occurring in the right coronary artery, left coronary artery, or branches of them. Now, if you have it in the right dominant situation versus left dominant situation, the consequences are kind of different. It's more dangerous when it comes to the left dominant configuration, and just some statistics as well. 40% of people have this left dominant configuration, so it's not rare, but it's more dangerous because if you were to have by chance that block or that pathology happening in the left coronary artery, that means you're going to lose supply to this whole region of blood, region of tissue supplied by the blood, right, from those vessels. So that's a very big danger. And it's often called the widowmaker because if that happens, because you're losing all that supply to the ventricles, also the posterior interventricular septum, all those crucial structures, it can be lethal and deadly. That's why we sort of emphasize that more. And yeah, that's sort of an important aspect to keep in mind. Okay, and then in terms of other clinical pathologies and ideas to keep in mind, probably a very important one over here is referred pain from the heart. So when it comes to referred pain, you can have two types of structures being irritated usually. One is myocardial irritation. So the muscle itself becomes irritated for some reason, and we'll talk about those reasons in a second. You also have pericardial irritation, where the layers around the heart, so the fibrous pericardium or the parietal pericardium usually become irritated. Remember, the visceral one doesn't really have pain innervation, so it's not going to really be affected that much. But let's say you have myocardial irritation first. So myocardial irritation can be caused by pathologies affecting the myocardium. For example, if you have a myocardial infarction where there's not enough blood reaching the myocardium, so they start dying off, right? Or yeah, they start dying off. And then you also have myocarditis, so inflammation of the myocardial tissue, and that can be because of an infective cause or other reasons as well. So yeah, myocardial infarction or myocarditis. If either of those occur, you're going to have the myocardium being affected, and so pain fibers in the myocardium are going to be stimulated, and they correspond to what's called visceral afferents. So basically, afferent or sensory fibers from the viscera, the heart, that travel back to the T1, T4 area, and your brain confuses them as coming from the T1, T4 dermatome. That's why even though your myocardium is actually being damaged, you won't actually feel a central or like off to the left a little bit pain on your chest. You'll actually experience more so of a chest and lower arm pain because that's the T1, T4 dermatome. And we often call this angina. And we'll talk more about that term itself a bit later as well. But pericardial irritation, that's caused by pericardial effusion or pericarditis. So basically any pathology that affects the pericardium. And pericardial effusion we'll come to in a second as well on the right there. But pericarditis is basically just inflammation of that pericardium. And that can be an infective cause as well. So when that happens, we're going to have the phrenic nerve being innervated, because if you remember, the phrenic nerve is the one innervating the fibrous and parietal pericardial layers of the heart. And so if that's irritated, the phrenic nerve corresponds to the C345 dermatomes. You've probably been hearing that over and over again in your lectures. C345 keeps the diaphragm alive because it's also innervating the diaphragm. But if you have that irritated, you actually have more of a shoulder and upper arm sort of pain, which is why we might see, I guess, myocardial referred pain becoming more towards the pericardial referred pain as the pathology spreads out and affects the pericardial layer as well. I'll talk about that in a second as well. So those are the main parts of referral, and you can therefore use that to understand where the pain is coming from. So if you see sort of pain from the chest lower arm region, it potentially could be a myocardial related cause or an upper limb cause. Well, that's sort of beyond this area for now. You also have, but when it's coming more in the shoulder region, it could be coming from potentially the pericardial layers, or even the diaphragm, because remember the diaphragm is innervated by the phrenic nerve as well. Okay, so that's the clinical correlation for heart referred pain. You also have cardiac tamponade shown on the right over here, which is also known as which is a consequence of pericardial effusion, where the pericardial effusion builds up and starts producing pathologies within the heart. So you have fluid accumulating in the pericardial space, right? And as a result, you get a number of consequences to the functioning of the heart. First of all, because that fluid is building up and actually compressing the heart on the inside, the heart's going to have impaired functioning. It's not going to be able to contract as forcefully and contract as well. And also, some of the blood supply coming into and out of it is going to be cut off or impaired as well. So the three things you really want to just keep in mind for the effects of this is, number one, you're going to have distant or muffled heart sounds. And that makes sense because there's a bunch of fluid building up. So if you're trying to auscultate and hear the heart sounds, the fluid's going to get in the way and you're not going to be able to hear it well. So it's going to sound muffled. Then you have decreased pulse pressure. And that makes sense because your heart can't contract as forcefully. And so that blood pressure is going to be lower throughout the body because the heart itself isn't contracting as hard as it once was. So decreased pulse pressure systemically, right? You also have distended neck veins. And that's because the blood that's trying to enter via, for example, the SVC is unable to, because the blood is pooling up inside the heart. And so there's going to be a column of blood that's building up in the SVC, and you'll see that as distended neck veins. And you can even look at that as the JVP being extended as well, which we'll come to in clinical skills. Those are the sort of three things you want to keep in mind when it comes to cardiac tamponade, the three different symptoms and signs. So those are the main things that you want to take away from the clinical correlation. And I hope that sort of made sense in terms of the anatomy and then the relevant clinical aspect of it. I've deliberately kept it kind of short just because I know that it can be very confusing with all the stuff that you learn in this cardiac area. So if you do want more details, though, I have linked to some more, I guess, detailed slides where they go over the individual aspects of the heart. For example, the ventricles and the atria. They have like whole slides dedicated to just the atria and the ventricles, if you want to go into that much detail, or even refer to their textbooks. But I'd recommend focusing on these areas. And then once you've got that big picture idea, then thinking about the more detailed aspects. Now, with that being said, I'll pass it on to our next topic.
Perfect. All right, so the next one is coronary circulation in health and disease, which is actually kind of a short one, and also potentially a misnomer. It should really be called just coronary artery disease, because that's basically all we're going to talk about. So the rundown of this is basically, we talked about the coronary arteries just before. And so I won't go too much over this because you guys have just been through it with Janel. But keep in mind that you have only a couple arteries really that supply basically the whole heart. Okay, so this is a very concentrated system and it has some very important points of failure. And remember, that gets heightened even further when you have a left dominant heart in which the left coronary artery supplies almost the entire heart, basically. So we have very few points of failure, i.e. there are a few spots where if you block the coronary arteries, you lose blood supply to a large area of heart, and it's supplying a both very important organ, because the heart is important to pumping your blood around your body, and also a very metabolically sort of needy organism. So you need a lot of oxygen for your heart to work. You need a lot of nutrients for your heart to work. Without those, it will just stop, which is what happens when we have a myocardial infarct or a heart attack. So that's basically what we're going to be talking about here. So coronary artery disease can be summed up as atherosclerosis in the coronary artery. So last week, we talked about atherosclerosis in general. That can happen anywhere in your body, but we care about a lot more when it happens in the heart, because if you have a clot somewhere in your hand or something, then you might lose blood supply to one of your fingers or something, which is bad. But it's not really, it's not remotely as bad as losing blood supply to, say, almost all of your heart if you have a left dominant heart and you're blocking your left coronary artery. The somewhat morbid thing about it is that you will get it. So you guys are maybe, what, 19, 20 at the moment. Half of you have atherosclerosis in your coronary arteries right now. And by the time you get to like middle age, pretty much all of you will have at least some. That's not talking about coronary artery disease by itself. By the time we talk about it as a disease, it's sort of a higher threshold. But even that, by the time you're 70, even like by the time you're maybe 50, you have a higher chance than not of having coronary artery disease, and it gets up to like ridiculously high percentages of the population as you get older. So it is just a natural to stretch maybe, but it's a very normal bodily process. Because it just happens when you have a circulatory system that's working and pumping blood. It's just a flaw in our biology. So we want to talk about two different types of plaques here. So we can have atherosclerosis, but there's different implications based on what type it is. So we have stable plaques, which are basically like, they are fairly well put together. There's a whole bunch of different, the components in it are sort of held together very nicely. You have usually a very thick fibrous cap. So I mentioned before, you can end up forming sort of a cap, a protein over the lesion as a whole. And if that cap is quite thick, then that makes it more stable and less likely to rupture. On the other hand, unstable plaques might have a thin cap, and they might have presence of things like extra lipid profiles and proteases, which can break stuff down. So the stable plaques, they'll sort of keep growing and they'll slowly exclude more and more of the artery, okay? And so that leads to angina pectoris, which is basically your heart says, oh, wait, this is weird, I'm not getting enough oxygen, and you start getting a pain response because you're having hypoxia in your cardiac muscle, basically. So we can do things about that, right? Because it's basically just a slow progressive narrowing of the coronary arteries. So we do things like we put in a stent and we blow it up and sort of widen the artery again. Unstable plaques, we care about those more because those are the ones that lead to things like heart attacks, okay? Because they can rupture rapidly as opposed to progressively occluding a blood vessel, like in stable plaques, and that can lead to really quick heart failure, especially if it happens high up in that tree. And again, things like the left dominant heart mean that you can have certain spots where just one block can have really, really serious consequences. So we think the inflammation increases your chances of having an unstable plaque, but it's still a bit hard to tell when you have an unstable plaque because a lot of the markers for unstable plaques are very similar to those for just inflammation in general. So we sometimes use imaging to identify them. That can help a little bit. And we can use, to a degree, anti-inflammatory therapy to reduce the risk of AMIs resulting from coronary artery disease. Okay. The other thing you need to know about CAD is the risk factors, particularly the modifiable ones. So non-modifiable stuff, there's age. As you get older, like I said, it's pretty much an inevitable progression. So you get much higher chances as you get older of having CAD. Initially, males have a higher chance, but when you get to postmenopause, so maybe like 60 years old, something like that, it becomes a higher chance in females. People of South Asian, Aboriginal, or Torres Strait Islander descent have a higher chance of getting CAD. And if your family has a history of CAD, then you have a higher chance. Modifiable risk factors, a lot of these will be stuff that you by now, like you're looking at a lot of conditions, you're starting to see that there are a lot of shared risk factors, especially for like cardiovascular stuff. So almost classic, like hypertension, hypercholesterolemia, smoking, diabetes, those are all really textbook stuff. Beyond that, we can also have inactivity, obesity, and poor diet, and they all sort of feed into the same thing. These are the same sort of risk factors that would lead to atherosclerosis in general. So CAD, which is basically just atherosclerosis in a particular place, is going to be at a heightened risk when these things happen. Okay, that's pretty much all. It's a pretty short and sharp topic, so feel free to ask any questions in the chat. Other than that, I'll hand off to our next presenter.
Yep. Thanks, James. I'll be taking us through basically the sort of drugs we want to talk about when we're thinking about angina and basically what we talked about here with having plaques and stuff. So we call them vasodilator agents, which kind of makes sense because we're trying to stop the kind of closing in of those coronary vessels by dilating them. Like we talked about briefly, there's three main types of angina: chronic stable, which is with atherosclerosis, and unstable, where atherosclerosis may lead to a thrombus formation in the case of an MI, a myocardial infarction. And there's a variant, or a vasospastic angina, which is essentially just a spasm of the coronary artery, where an unpredictable spasm would decrease the blood flow, which causes the demand of those myocardiocytes to exceed the blood supply, leading to angina. And this is the key underlying principle for all types of angina. It's just that there's more demand than there is blood supply to the heart. As for the symptoms, we talked about this earlier, but mainly it's just chest pain, and some people present with shortness of breath. It's known that females also present differently with nausea, vomiting, back and jaw pain. And if you guys think a little bit about heart attacks, I think this is also something commonly talked about, where females present differently with stuff like that. We talked about the risk factors just then, but basically, when angina worsens, it probably is a case of unstable angina, and when it lasts for a decently long time, that's when we really need urgent medical care. So when we think about drugs for angina, we're thinking about three main things: beta-adrenoceptor antagonists, calcium channel blockers, and nitrovasodilators, with each of them being indicated for specific types of angina as well. Starting us off with beta-adrenoceptor antagonists. So if we think about the sympathetic system, activation of it leads to increased heart rate, increased cardiac output. So by decreasing the sympathetic drive, we decrease the metabolic demand. So we think back to the main principle of angina, which is just that the demand is greater than the supply of oxygen. So by decreasing the metabolic demand of the heart, we relieve symptoms of angina, but also by decreasing heart rate. If you guys remember, think back to Ginal's excellent little talk about coronary arteries and how they are filled during diastole via those aortic valves. If you have a prolonged period of diastole, that leads to increased coronary perfusion, which means that it will help us with angina. The other method of action is decreasing renin release. Renin is part of the renin-angiotensin system, which I'll go into a bit more depth later, but essentially, we're going to decrease total peripheral resistance. And that is basically by dilating the vessels of the periphery. So by dilating those vessels, we decrease resistance. And because of that, we decrease the demand on the cardiac muscle, because there's lesser resistance that the left ventricle must pump against to send blood to the rest of the body. I'll be talking about afterload and preload a little bit more. I know it was mentioned earlier, but just, yeah, I'll talk about that in a second. For these drugs, indications are as such: angina, some more other stuff, but mainly we just want to know that it's exertional angina. Yeah, and as for adverse effects, when we do beta-adrenoceptor antagonists, we must remember that even if we try to have selective action at the beta-1 adrenoceptors, which is what is specifically for the heart, we are going to have beta-2 blocking effects as well. And beta-2 blocking effects leads to things like bronchoconstriction, which we don't really want. So it's an adverse effect. And we can also end up with bradycardia if sympathetic drive is decreased too much, AV block leading to arrhythmias, claudication, exercise intolerance, impotence as well. If the drug is lipid soluble, leads to depression, sedation, sleep issues. And for diabetes, it is a concern for prolonging hyperglycemia or hypoglycemia. So like I said, we want to typically use beta-1 antagonists like atenolol, but propranolol can be used. We don't want to use that because it's beta-1 and beta-2 and it's non-cardioselective. However, we got to understand that beta-1 antagonists can still have some beta-2 effect. And it's important to note that beta-1 adrenal receptor antagonists are not really used in vasospastic angina, and it's really only exertional angina prophylaxis. And the reason for that is, actually, wait, yeah, it's just mainly for exertional angina. So, actually, wait, I just want to address this part for a second. So I talked about how beta-2 blocking leads to bronchoconstriction, but it can actually also lead to vasoconstriction, which we definitely don't want, because that will decrease the blood supply to the heart, which is why we don't want to use it in vasospastic angina, because that has a sudden decrease in perfusion. So beta-1 really just reduces metabolic demand as the main function, rather than vasodilation. The second type is calcium channel blockers. So any muscle cell has calcium, uses calcium as a means to cause muscle contraction, and calcium channel blockers essentially block calcium voltage channels. And there are two main classes. We have DHP, dihydropyridine, and non-dihydropyridine calcium channel blockers. So the key difference between these two is that dihydropyridine has effects on peripheral smooth muscle, while non-dihydropyridine has main effects on cardiac muscle. So by blocking calcium voltage gated channels, we essentially decrease things like the blood pressure. We decrease the activity of these smooth muscles. So for example, for dihydropyridine, we would decrease the blood pressure and cause vasodilation because we're causing those peripheral smooth muscles to relax. So since DHP is for peripheral vessels, it's more antihypertensive, and non-DHP is for antiarrhythmic, since this would cause decrease in things like, it's more related to the cardiac system, or like to the heart specifically. And we want to use them in angina because by decreasing the total peripheral resistance, we decrease the cardiac workload, because the heart doesn't need to pump hard in order to overcome the resistance in the peripheral vessels, because we're dilating those peripheral vessels. By decreasing metabolic demand, it helps with angina. We can use both of them, but the order of priority really goes from verapamil to diltiazem to nifedipine. And here's just like a bit of more detail on how they work. As for contraindications, we know that non-DHP works specifically on the heart, so it can cause excessive bradycardia and potentially impair electrical conduction, depress contractility. So if you're using stuff like beta blockers alongside it, which already causes bradycardia, this would exacerbate it, so you don't want to use them together. So we have to be careful there. If you have conduction defects, impaired electrical conduction is a contraindication. And heart failure caused by systolic dysfunction. We'll talk about this. It'll make more sense once we talk about heart failure, but it kind of makes sense how you don't want to depress contractility when your heart is not able to pump properly in the first place, which is heart failure, specifically when there's systolic dysfunction, when your heart can't pump out of the ventricle properly. Here's some adverse effects for that. Okay, so nitrovasodilators. So this is a relatively new system, or like just something that's a little bit different. Essentially, our endothelium releases nitric oxides, which relax vascular smooth muscle and cause vasodilation. That's just the key thing. It does a bunch of other stuff like platelet aggregation inhibition. It's antithrombotic and anti-inflammatory, but I just want you to pay attention to vasodilation. So by introducing nitrodilators or nitrovasodilators, we can mimic this endogenous nitric oxide, and this will act directly on vascular smooth muscle. So pretty straightforward. Basically, the endothelium releases stuff that helps with smooth muscle relaxation. So we want to use a drug that mimics that. The way in which it does this is basically NO causes this entire cascade down here with producing guanylyl cyclase to increased cyclic GMP production, which eventually inhibits calcium entry. So it's going back to calcium, kind of like calcium channel blockers, and causing smooth muscle relaxation. And this is how that works. So by dilation of vessels being the main pathway, it's useful in a bunch of ways. So for example, if we dilate the venous system, we decrease venous pressure. And by decreasing the venous pressure, we allow for more blood to stay in the venous system. So it decreases the amount of blood entering the heart per se, and that decreases the amount of cardiac workload on the heart. Since there's more blood in the venous system, there's less blood in the arterial system. And when the left ventricle is pumping out into the arterial system, you overall have lesser pressure to fight against. So by venous dilation, you are just adding more blood to the venous circulation relatively. Arterial dilation, so this makes sense because when we cause the dilation of the vessels in the arterial system, decreases peripheral resistance and consequently decreases cardiac consumption. Coronary dilation, pretty straightforward. By dilating, we have more coronary blood flow, so we're able to meet the demand, so we don't have angina. And this is specifically for variant angina. So nitral vasodilators are very important in variant angina. Okay, so here's an example. So nitroglycerin is the example that we talk about. We give it sublingually / transdermally. There's some side effects related to hypotension. Makes sense because we're dilating vessels. Reflex tachycardia. So that's basically when so because of the drop in blood pressure, to compensate for the drop in blood pressure, your heart may pump more. And that may exacerbate angina, so you need to be careful with that. Because of cerebral vasodilation, it leads to headache, and flushing because of the peripheral vasodilation. Okay, so one thing about it can develop tolerance, so you want to have nitrate-free periods. And a specific contraindication is Viagra or sildenafil, because it acts on the cyclic GMP system as well. So it will have a pretty additive excessive effect. Okay, so those are the 3 drugs for angina. So now we're going to talk about inotropic agents, which is stuff we're going to talk about for heart failure. So what is heart failure? Heart failure is basically when we're pumping too little blood. We talked about this earlier in this presentation, so I'm going to run through it pretty quickly. Essentially, you have acute and chronic heart failure. Acute heart failure is precipitated by events like an AMI, or it's a flaring up of a chronic heart failure, which leads to acute heart failure. There's 2 main types of chronic heart failure. If you look on the diagram on the right, it kind of depicts it pretty well. So this is normal heart. If you have systolic dysfunction, so that is basically when the ventricles are expanded and enlarged. This reduces the amount of contraction they can do, which is systolic problem. So it reduces the total ejection fraction. And that's heart failure with reduced ejection fraction. Diastolic dysfunction is when, if you guys remember, when the stenosis, you might cause, this might lead to a thickening of the walls of the heart. So you have a preserved ejection fraction, meaning the fraction of the blood leaving the heart is the same, meaning it can pump a decent amount. However, because it's thick, or the ventricles are thick, it is unable to fill the chambers of the heart properly. So that's diastolic heart failure. So it eventually leads to decreased blood outflow from the heart. So 2 pharmacological agents, the 2 main principles we're going to talk about is increasing contractility and decreasing workload. Because by increasing contractility, we help with something like systolic dysfunction, because we can pump more. And by decreasing workload, by making it easier for the heart to pump more blood, that obviously helps us with heart failure. Okay, so I said I'll talk about preload and afterload super quickly. So in the context of what we're talking about, we want to use the left ventricle as a point of reference for most of these things. So for example, preload, when I talk about preload, I'm thinking about the stretching of the cardiomyocytes prior to contraction. So probably the left ventricle. So we're thinking about left or the right ventricle, really. But if we take the left ventricle as an example, and if we're talking about the stretching of those cardiomyocytes, when we do have increased end diastolic pressure, meaning at the end of diastole, if there's a lot of blood in the left ventricle, then it will stretch a lot, and then that is essentially increased preload. And when it stretches a lot, you'll have more contraction. And this happens when we increase blood volume or venoconstriction. So when the venous system is constricted, we have more blood in the arterial system and likely entering the heart as well. Just because the peripheral blood, like there's not enough room for peripheral blood to exist outside in the venous system. So after load, if we think about the left ventricle again, this is resistance to the left ventricle emptying. So after load is basically the pressure that you have against the ventricular emptying. So this happens, for example, in peripheral vasoconstriction or arterial vasoconstriction. So if the peripheral arteries are constricted, then you're going to have more pressure and your outflow is going to increase. So as you can probably tell, if you increase preload, your cardiac output would increase. But if you increase afterload, your cardiac output would decrease. Okay, so here's like a little loop that you might fall into when you have heart failure. So when you decrease cardiac output, this will cardiac output is essentially the amount of blood leaving the heart. So if you decrease that, you're going to decrease arterial pressure when you're pumping from the left ventricle into the arteries. And this, in order to compensate for that, it leads to vasoconstriction. And what does vasoconstriction do? So increased vasoconstriction leads to increased resistance to emptying, which is increased afterload. And increased afterload leads to a further decrease in cardiac output. So this cycle continues where you have decreased arterial pressure, vasoconstriction to compensate, and then decreased cardiac output again. So that was a bit about heart failure. Now let's talk about how we can help treat it. So the first thing we always talk about is lifestyle changes. The second thing is decreasing cardiac workload. And the third thing is increasing cardiac contractility. So the main way by which we decrease cardiac workload is by decreasing afterload. So if we vasodilate the peripheral vessels, we decrease the resistance to emptying. And that decrease in afterload would increase cardiac output. So the first one I'm going to talk about is angiotensin, or the angiotensin system. Super quickly, this is the renin-angiotensin-aldosterone system. You'll go into more depth in this later. I just want you to know that there's a big system where renin plays a role, angiotensin plays a role, and angiotensin is something that is converted to angiotensin II thanks to something we call ACE, released by the lungs and the kidneys. And angiotensin has a bunch of effects, which all, at the end of the day, increase blood pressure. For example, by tubular sodium reabsorption, we're going to reabsorb water back into the blood. By reabsorbing water into the blood, we increase the amount of volume of water, or the blood volume, which increases the pressure, or the blood pressure. Similarly, we increase the aldosterone secretion, which is a hormone, which literally does this. And by increasing aldosterone secretion, we increase blood pressure. By increasing sympathetic activity, we increase cardiac sort of contractility and the work that the heart does, and that increases blood pressure. We also do vasoconstriction, which obviously increases blood pressure as well, and ADH secretion. So the two main hormones is aldosterone and ADH. ADH is going to do the same thing. It's going to cause retention of water in the blood. And by doing that, you increase the blood volume, which increases blood pressure. So one more thing is that this system can cause heart hypertrophy and fibrosis as well. Which kind of makes sense. Like heart hypertrophy is to compensate for the increase in blood pressure, so you got to pump more and harder. And fibrosis is damage to the heart, or the replacing damaged tissue by fibrous stuff. Okay, so ACE inhibitors. This is the first class. So over here, we're targeting the ACE over here. By inhibiting this, we stop the system from working, and we stop angiotensin II from being formed and having all these effects. So an ACE inhibitor, long form is angiotensin converting enzyme, which makes sense because we're converting from 1 to 2. Anyway, the main thing for the naming, it always ends with pril, regardless of whatever they give you. If it ends with pril, it's going to be an ACE inhibitor. So it can have a hypotensive effect since we're affecting hypertension or opposing hypertension. One more thing is that it inhibits bradykinin breakdown. So bradykinin is something that is seen in inflammatory responses. So by inhibiting its breakdown, we increase bradykinin, which increases local vasodilation and leads to increased inflammation. So a common side effect of ACE inhibitors is often coughing, which is linked to some due to increase in bradykinin. We use this stuff in hypertension and obviously heart failure, because we're talking about that now, diabetic nephropathy as well. Because in diabetic nephropathy, you have an increase in blood pressure, which causes damage to the nephrons, nephropathy of the kidneys. So by stopping that, by decreasing hypertension, we can help with that. Contraindication is pregnancy. Okay, so we want to keep an eye on the different levels of ions, like potassium and sodium, that these drugs do, because that will help us figure out what will, if we can use certain drugs with other certain drugs. For example, ACE inhibitors cause hyperkalemia. So if we were to go back and use a potassium sparing diuretic, so don't worry about what this means, but basically this will increase potassium. That's going to cause an additive effect with hyperkalemia, and that's going to have negative effects on the body. So basically we don't want that. Rash, itch, and angioedema as well. Okay, so the next one is angiotensin receptor blockers, ARBs. So it works at by blocking the receptors of angiotensin II. So it inhibits the activity of angiotensin II. It ends with sartan. So anything that ends with sartan is an ARB. The receptor is called AT1, and receptor. It's an antagonist to that. Obviously, overall leads to a hypotensive effect. Similar indications, but one more thing is that it doesn't cause the increase in bradykinin levels. Because of that, it is also indicated in people who are intolerant to ACE inhibitors because of the cough or other side effects that ACE inhibitors has for them. Contraindications of pregnancy, and literally the same side effects as before. Hyperkalemia as well. I should get rid of cough, so there's no cough. There's also something called bilateral renal artery stenosis, which can happen. Okay, so the second one is diuretics. So I talked about potassium sparing diuretics. I hinted at that just then. So if we go into this in a little bit more depth, a diuretic is basically something that will increase urine output. And by increasing urine output, we decrease blood volume and we decrease blood pressure. That's essentially the mode of action. And we have three main types of diuretics. So since we're talking about urine, we're talking about kidneys, we're talking about the nephron, which is the functional unit of the kidney. And there's like, the nephron kind of looks like this. You'll go into this in more depth later on in second year, so don't worry too much. Just know that there's three main types of diuretics and act at different parts. One is the loop diuretic, which acts at the thick ascending limb of the loop of Henle, which is this loop here. So this loop diuretic, main class is, and it is the most efficacious diuretic. So it's the most effective one, and it's because of that, it's used when other diuretics typically lack of efficacy. It leads to volume overload. It's indicated in volume overload surrounding specifically edema. So when you have pulmonary edema or congestive heart failure, chronic heart failure, to stop pooling of blood, we want to mop up the blood by reducing blood volume. Okay, so this causes hypokalemia, meaning this can be used as inhibitors, ARBs, potassium sparing, because it's the opposite effect of hyperkalemia. One thing to note is that it increases digoxin toxicity. We'll talk about digoxin in a second. It causes hypovolemia, which makes sense because by losing water, we lose volume. It causes dizziness, hypotension, and hearing loss. Thiazide diuretics. So it's a thing called hydrochlorothiazide. This works at this point here, which is the distal convoluted tubule. And it filters like basically a lesser amount than the loop. So it's indicated in mild to moderate edema, mild to moderate hypertension. So just like sort of like a weaker version of loop diuretics. And same stuff here. So hypokalemia, hypovolemia, hearing loss. Potassium sparing diuretics. So this is the last one, is spironolactone. This is an aldosterone antagonist. So basically, the point is that this leads to hyperkalemia, while the other diuretics led to hypokalemia. Because of that, we can use it in combination with thiazides and loop diuretics. And it's also indicated in hyperaldosteronism. So that's a condition when you have too much aldosterone. So by antagonizing it, you can treat that. It has reduced sodium reabsorption, which will eventually lead to hyponatremia, which I just haven't mentioned, but that's also another thing. Some adverse effects. One more thing is that aldosterone, we talked about heart fibrosis earlier. Another thing is that aldosterone can promote heart fibrosis. So by antagonizing that, you prevent heart fibrosis. So this is particularly relevant, makes it more relevant in heart failure because of that. Okay, so beta blockers, I'll just talk about this super quickly because there's not much detail on it, but it's a bit counterintuitive. You would imagine that by blocking beta adrenoceptors, you would decrease sympathetic action and cause decreased contraction and action of the heart. However, there's evidence that it works in stable heart failure. But yeah, just keep in mind that it works in stable heart failure. So we talked about decreasing workload. Next thing is to increase cardiac contractility. We do this through positive inotropes. Inotropes is like a drug that changes contractility. So you can have positive or negative inotropes. Since we're going to increase, we talk about positive inotropes. And it's digoxin and dobutamine, which are the two key ones. So starting off with digoxin. If you might recall that I talked about how hypokalemia increases digoxin toxicity. So that goes to show that you can't use it with like loop and thiazide diuretics. But anyway, the way that digoxin works, it's called a cardiac glycoside, but the main way that it works is at the site of myocardiocytes, so like at the specific cardiac muscle cells, it inhibits the sodium potassium pump. Now, this raises intracellular sodium because the sodium potassium pump wants to remove sodium, so it increases sodium inside. And this consequently increases intracellular calcium. We know that we want calcium in order to increase contraction, because calcium leads to increased contraction. So we end up with increased or stronger cardiac contraction. So digoxin is typically used in heart failure with reduced ejection fraction. So we talked about this earlier, where reduced ejection fraction is when it's more dilated, when it just can't pump the blood out properly. And it's not first line, so it's usually when it's already being treated. Also with atrial fibrillation, to help with arrhythmias. However, it can also cause arrhythmias. So it has actually quite toxic side effect profile. And there's a narrow therapeutic window as well, which is the gap between toxicity and inefficacy. So you got to be careful of renal function because it's renally excreted. So you got to make sure that they don't, that it actually works and they don't get messed up because of it. A lot of this is to do with vagus nerve stimulation. So there's a lot of GIT stuff, anorexia, nausea and vomiting, diarrhea, and neuro stuff include visual disturbances, agitation. I talked about hypokalemia, so that's loop and thiazide diuretics. The reason for that is because by inhibiting these sodium potassium pumps, inhibiting sodium potassium pumps is its main form of action. but when you have hypokalemia, you have decreased competition at these sodium potassium pumps, since you have decreased potassium. So this leads to greater digoxin binding and greater effect, and which leads to greater adverse effects. So you gotta be careful about that. And yeah. The last one that we're going to talk about is dobutamine, beta-1 adrenoceptor agonist. So we talked about beta blockers actually working for heart failure. So beta not blockers, but beta agonists also seem to have some help. By stimulating sympathetic activity, we promote heart contractility and stuff. One key thing is that it has a short limited IV use because of receptor downregulation. So our body essentially adapts to it. So it doesn't really help us that much, but it can be pretty useful in the short term. And that is the end of that stuff. Thanks for listening.
Awesome. Thanks for that, Deepak. So I'll be taking you guys for basically the clinical skills part of today's section. Now, I do realize that we are only like less than halfway through the slide deck, and we've only really got like half an hour left in terms of the 2 hours allocated time. So if you need to leave, that's completely okay, and we understand. But this is, if I say so myself, probably the most important section of just like heart stuff in general, just because this is the things that you're going to be doing in a clinical setting. And as long as you understand some of the basic anatomy that we've run through, a little bit about the basic pharmacology, a little bit about the basic physiology, all of this should make sense. So don't be scared or worried if some of the content we've covered is fairly complicated, or you might think it's a little bit niche. That's okay. When we come here, you'll kind of be able to bring all that knowledge back to the same place in terms of an actual real patient. So let me get started. We're starting off with cardiovascular system physical examination, and then we'll move on to ECGs. So just a brief, like a really quick overview before I go into the details. Remember that with your MSK exams, so whether it was lower limb, upper limb, whether it was back, whatever it was, you had a set structure, right? You had to look first, and you had to feel or palpate, then you had to move different parts, different joints, and then you had to do special tests. Over here, when you get to sort of organ level, or when you get to systems, it becomes a little bit more complicated, and it generally will follow a similar, like whatever organ you pick, it'll probably follow a very similar order to the one that I'm showing you now with heart. So I've kind of divided it up into the 4 steps that kind of make it easier for me to remember. You definitely will look first. So general inspection always comes first. Let me just get a pointer up actually. So you always have look. That's always where you start. Then you go on to vital signs, and I'm not going to be covering too much about vital signs now. Maybe a little bit in the context of heart, because obviously you need to look at blood pressure, you need to look at blood oxygen and things like that, but I'm not going to focus on that too much today. Then we go into peripheral examination. So you go upper limb, face and neck, and then lower limb, and then finally the precordial meaning basically the chest. So you're inspecting, palpating, percussing, and then auscultating everything around the chest, namely the heart. I think we've been told that you do peripheral exam first and then precordial, but I believe in like an emergency setting, you would definitely do the chest first and probably more urgently, and then you'd probably do the peripherals, also I've heard. So when you look, what are you looking for? You have a couple of things starting with D, which does make it easier. So you've got discomfort, distress. You also want to look at their posture. You want to look at whether they're breathing funny. So they're having difficulties breathing, because we know that one of the major signs of potentially left-sided heart failure is fluid buildup in the lungs. So that could be something that causes dyspnea. You can get dehydration, and dehydration is not like a direct symptom of heart failure. It's more if they're not drinking enough, then it could be something that precipitates them, feeling faint or something like that, or having low cardiac output. Body build, cachexia, which is basically just like feeling or just looking really thin. And speaking of looking really thin, you're looking for a lot of congenital conditions, namely Marfan syndrome. Now, I'm not sure if you guys have come across this before or heard of it. Just a connective tissue appearance is someone who looks really tall, really thin. Maybe they've got sort of a long face, and there's some other features that are labeled here. But the main reason why we look for this is because we know that the heart, a lot of the framework of the heart is connective tissue. All sorts of other organs are as well, but the heart being really important, including the valves. So if you've got a connective tissue disorder, you're more predisposed to having heart problems. You also want to look for other genetic or congenital disorders like Down syndrome and Turner syndrome. Now, if you're doing an OSCE, or you're probably not going to do an OSCE this year, but if you're in a clinic, you don't want to mention Turner syndrome if you've got a biological male, because Turner loss of an X chromosome, so you have an XO configuration. And then Marfan's we sort of discussed, and I might have given away the answer, but remember that it's the connective tissue disorder. And really, this is your chance to comment on anything that you can visually see in this patient. So even looking at equipment around them that could give you some indicators, or even medications or medication boxes. All right. Vital signs, as you can see, I skipped, but you really want to be looking for their blood pressure. You want to look at the pulses in their upper limb, lower limb, maybe the neck, and then blood ox. Then you're looking at the peripheral exam. You start off with your upper limb most of the time, and you want to work, sort of distally, and then work up more proximally. So you start off with the hands. You have the nails, and I've kind of ordered it like this to hopefully make it easier to remember. At the nails, you're looking for really 4 things. You're looking for clubbing, and clubbing is not a cardiac specific sort of sign, but in the cardiac setting, we're looking at subacute endocarditis as one of the common causes. And the way that you look for clubbing is you get them to hold out usually the index fingers, and you kind of go like this. You can't really see that here just because of the camera, but you should be able to see a little diamond window in the middle. If there's that diamond window not there anymore, that's because their sort of fingers have become potentially like really inflamed, and that's an early sign of endocarditis. Peripheral cyanosis is going to be your classic symptom of heart failure. You're not getting enough cardiac output, so you get your fingers maybe becoming a little bit blue. Capillary refill is similar. This time you're just pressing the tip of the finger, and seeing how long does it take for blood to come back. It should take about 2 to 3 seconds. If it doesn't, again, you're considering potential decreases in cardiac output or similar conditions. Splinter hemorrhages are very classic symptoms of infective endocarditis. So you'll see like white lines on their nails. And then when you go into fingers, there's really only one thing you're looking for. If you look between the fingers, you're looking for tar staining. So signs that this person might be a smoker and therefore at risk of heart problems. On the dorsal aspect, so think about the back of the hand, you're looking for tendon xanthomata. So indicates there's cholesterol deposits, and again, a risk factor for heart problems. You can also look for tendon xanthomata around the elbow, but we're focusing on the hands for now. On the palmar side, so on the front, you're looking for, these are probably the most important ones. Again, infective endocarditis, we're looking for Osler nodes and Janeway lesions. Now the difference is they kind of look similar, but Osler nodes are going to be tender and painful, whereas Janeway lesions are usually not. And this could be because Janeway lesions are more subacute, whereas Osler nodes are kind of, this condition has already been elapsed for quite some time. Palmar creases, if you look at those, you notice maybe in the creases that they look a little bit pale, whereas the rest of the hand is kind of fine. That could be an early sign of anemia. So they're not getting enough oxygen to the rest of the body, or they don't have enough red blood cells going around. So that's the hands. Then at the wrist, this is what I mentioned with the vital signs. You want to take the radial pulse and mention things like rhythm, regularities, the volume fine. You want to think about radial delay and radiofemoral delay. Now, this harks back a little bit to the anatomy of the aortic arch, and some of the reasons why these occur should be apparent to you now that you have some knowledge of the aortic arch and what it looks like. With regards to radial delay, remember that you've got the subclavian arteries that are supplying the hands and the upper limb. So if you've got a delay, for example, between the left-hand side and the right-hand side, it could be because one of these subclavian arteries on the affected side is stenosed. In other words, it is the lumen size is restricted, so not enough blood is going through. Or you could have a proximal aortic coarctation. So if you have something sort of, and again, you can't see my pointer too much because it's red, but if you have it sort of in this region and going down, like here, that could mean that one subclavian artery has good perfusion, the other one has not so good perfusion. So that's why you can get a delay. Radiofemoral delay is where you check the radial pulse in the wrist and then the femoral pulse in the femoral triangle. And the reason why this could happen is potentially a distal aortic coarctation. So once you've gone past the subclavian arteries, if you go down here, if you've got stenosis happening or coarctation, then you will have good perfusion to both sides for the radial pulses, but not good perfusion going down to the lower limbs. So think back to the anatomy, and some of the reasons why these delays can happen might make a bit more sense. In the face, again, break it down into sort of the general face, the eyes, and then the mouth. If you're thinking about the general face, just have a look quickly at their cheeks. If it's kind of red, you might be considering a problem with mitral stenosis. And the reason why, again, could be backflow of blood going up to the face so that you get sort of flushing. With the eyes, you're thinking about xanthelasma, kind of like xanthomata, but this time it's on the eyelid. So again, a sign of cholesterol or lipids building up. Jaundice, you can, if you kind of pull the eyelids up and ask them to look down, so you can see the sclera, you might notice yellowness, or it might be apparent even if you don't really do that sort of maneuver, and that's an early sign of jaundice. Arcus senilis is a gray ring around the pupils. From what I'm aware, I think it can be just age-related. I'm not really sure how that links too much to cardiac pathology, but I believe it's just something important to look at. If you can see around the pupils gray rings, that's positive for arcus senilis. And pallor, if you try and depress their eyelids, so if you just kind of go like this, get them to look up maybe, and you look at the bottoms of the eyelids, then you might notice a pale conjunctiva, again, an early sign of anemia. In the mouth, signs of Marfan syndrome can include high arched palate, so that connective tissue disorder we talked about. Central cyanosis, so we talked about peripheral cyanosis, but centrally you might notice it as a blue tongue or really blue lips. And then you look at the teeth and gums for their sort of oral and dental hygiene. You're looking for cavities, gingivitis. And again, why? Remember back to that microbiology lecture where I said, if you have bad oral hygiene, you can get some of those surface bacteria like strep going in and leading to infective endocarditis when they enter the circulation. So this again can be a really important risk factor. All right, and probably the most important part of the peripheral exam is going to be the neck. So you check the carotid pulse, and there are a couple of things you want to note. Is it good volume? So have we got enough cardiac output? I'm not sure, you guys wouldn't have covered carotids or jugular veins before. So I won't really focus too much on the anatomy. I'll make it as simple as possible. Just remember that the carotid also comes off left and right. They also come off the aortic arch in different ways. And those are going up to the head and neck. So if it's going up to the head and neck, this is not the carotid, but it's going to go up there. You're looking for volume and character, whether it's, it's nice and fluid or whether there's any sort of obstructions. Now, there are two things you can feel and listen for. You're feeling for thrills. So when you kind of put your hand over it and you feel that it's sort of shaky, you might notice that there's a potential amount of stenosis happening in the carotid arteries, or it's stenosis in the actual valves in the heart, which is leading to turbulence building up in the carotids. You can also listen for bruit. So this is when you get to auscultation, which we haven't discussed yet, but you can listen here and think about whether there's turbulence in those arteries. These are effectively sort of thinking about the same sort of pathologies, but there are two different ways of going about doing it. And then jugular veins, specifically the internal jugular vein, you're thinking about whether it's distended or not. Now, why could that be the case? If you think about right-sided heart failure, remember what's coming into the right side of the heart, or more specifically the right atrium. You've got the inferior vena cava, superior vena cava. Some of the tributaries of some of those veins are going to be the brachiocephalic veins, and then off of that will be the internal jugular. So the internal jugular is sort of like a direct look into the right atrium, and it's sort of positioned right on top of the atrium. So you can have a really, really nice view of what is the pressure like within the right atrium. Now, if there's a lot of pressure in the right atrium, that could be a sign of potentially right-sided heart failure. And the way we can see that is the jugular vein, which you can see in the neck here, would be kind of distended. Normally, it's going to be 3 centimeters above the sternal angle, yet another use of that sternal angle that we talked about in our previous lecture on the thorax. If it's more than 3 centimeters, then that's positive for distension. Now, how do you actually measure this? You get the patient to lie down like this at a 45-degree angle, and that's just the prescribed angle so you can see it better and you can measure the height. And what you do is you palpate that sternal angle. You usually get 2 rulers, but you can just see it with the naked eye sometimes. You get a ruler going up, get a ruler going to the side, and measure what was the height of that JVP. And if it's more than 3 centimeters, that's not that's a sign of potentially right-sided heart failure. Turn the head to the left most of the time. And one way that you can get the internal jugular to kind of pop up a little bit better, if you can't see it, then you can bring in action the abdominojugular reflux or the reflex. You press the abdomen and specifically the liver region for about 10 seconds. And what that's kind of theoretically supposed to do is cause a backflow of venous blood that's exiting and entering in the liver to go up to the, or like force it up to the right atrium, and then therefore up to the IJV. So that's that, what you do with the jugular vein. Now, some practical points that you really want to keep in mind when you're doing this on a real patient is with the carotid, because there you've got the carotid sinus. And again, you're hearing that word sinus. It's just a enlargement of a particular vessel, or it can be an air-filled space. In this case, the carotid sinus is monitoring blood pressure. So if you press it physically, rather than it actually measuring anything, it might think you've got a really high blood pressure, and then it's going to try and correct it by lowering the blood pressure for no real good reason. So you might cause this person to go into sort of hypotension. You don't want to try and palpate on both sides either. And the reason why is because the carotid vessels are the only vessels that are supplying the head and neck, and so the brain too. Which means if you try and palpate on both sides and stop blood entering into the brain, this person might faint. So it's not a good idea to palpate on both sides, do it one at a time. With regards to the difference between the carotid pulse and the JVP, because they are basically located in the same sort of triangles of the neck, with the JVP, the important thing is that it pulses twice. And I'm going to go into that in the next slide, so you don't need to check your notes out for now. I'll go into the diagram what that looks like. It's a biphasic sort of pulse. So you'll see it flutter twice. But the cool thing is that although it's visible, you're not going to be able to palpate it. If you try and put your fingers on it and feel for those pulses, it'll just disappear, because veins are collapsible. They're not going to really be that palpable. But the main thing is JVP is an indicator of right atrial pressure, which is what we discussed. The carotid probably is more intuitive, pulses once because it's just pulsing with the beat of the heart. And it's palpable, so you can feel it, but generally it's not visible because it's a little bit deeper. So you need to put your fingers like this on the side, and so you can feel you can probably feel it now if you tried. And that's going to be an indicator of left ventricular pressure, because that's just an outflow artery. So speaking of the JVP, you do not need to know this wave in and out. I'm only just understanding some of this. Like, I don't really know how it works that well yet, but it kind of looks like this. And it shows you why I said it was biphasic. So it's got this one big wave here. This wave is a little bit smaller, so you might not notice it, but then you've got this wave here. So you've got two waves happening. Now, there are certain events that cause these waves to occur. And again, if you just think about it from the perspective of the right atrium and it being an indicator of what's happening in that chamber, then this should make sense. So think about the right atrium. And some ways to remember this, some mnemonics, is that with A, what you have is the atria contracting. And why is the atria contracting? It's trying to push blood into the ventricle. But what that's going to do also is potentially push a little bit of blood back up into the veins that are coming into the right atrium, including the IJV. So you'll get a little spike in that IJV pressure. Next, you're going to have the X descent, and that's just when your atria is done, it's relaxing, and so that level is going to come back down. So that's X for relaxation. With the C wave, you now have the tricuspid valve, so separating the atria and the ventricle, closing, because all the atrium is done, the ventricles are going to get ready to contract. And when the tricuspid valve closes, the right ventricle contracts. That'll also cause a little bit of a jump in the IJV, just because the ventricle is contracting, putting a bit of pressure on the right atrium and putting a bit of pressure on the IJV. You get a larger X descent happening a bit after that for similar reasons. You get the V wave, which is when, again, the ventricles are contracting. Once that's done, the right atrium will start to fill again, which is why you get an increase in pressure once more. And then finally, with the Y wave, you get further emptying of the atrium as it contracts, and then you end up back where the A wave is, the atria contracting. Now, again, not important for you to know any of this. The main idea for this section is just to show you why you get two waves. There's a link to a video. I think I've put it in the comments. If I haven't, let me know and I'll link it. But I think it's in your clinical skills booklet. And it's a really, really good video because it visualizes all of this rather than me just saying it verbally. Okay, now we come to the precordial exam. So we're thinking about inspection and palpation in this case. So when you inspect, firstly, you want to look for any deformities in the patient's chest wall. There are a couple just to keep in mind. So you've got pigeon, and they've got sort of more scientific terms, but for our purposes, Pigeon is going to be kind of, if you think about a pigeon, they kind of always have their chest out. That's kind of what this looks like. So pectus carinatum, as shown here. Funnel chest is just it sort of going in, so it's going inside, and you can imagine that could put a bit more pressure on the heart, and the heart doesn't have as much space. And then barrel chest is going to be where you've got the entire, not just the sternum popping out, but you've got the ribs also popping out. And that could be a sign of lung pathology, but in this case, you want to note it down as potentially related to the heart. Other stuff, just general things you're all familiar with: scars, rashes. You notice any pacemaker, and you won't be able to see the pacemaker. You might hear evidence of it from the patient, but the way you can see the pacemaker is you can think about surgical scars. So usually under the clavicle on either side, you might see that scar for when they inserted it. Breathing patterns, again, an indication of right-sided. Discussed thrills before, but with heaves, you want to use the heel of your hand. So heaves, heel, that might make it easier to remember. And those are just really strong beats. So it can be a sign of pathology if that's the case. So two major places you want to look at is going to be the left-hand side and or the lower left parasternal border. That's a sign of right ventricular hypertrophy. And then the apex beat, because it's the left ventricle, that's a sign of left ventricular hypertrophy. With thrills, you're just going to be using the flats of your hands, and you're thinking about just looking over all the valve areas, which we'll go into when we come to auscultation. If you feel over it and you notice that it kind of feels like there's a I don't know another word for a thrill, it's kind of just like a flutter, that might indicate that some of the valves are incompetent. Okay, now this is the most high yield part. So we've discussed where are some of these valves located. Unfortunately, you will have to remember this, and it'll come in a lot of use even for next year and when you get into clinical years. You want to remember where the mitral, tricuspid, pulmonary, aortic valve are located. Now, I had some confusion with mostly the pulmonary and aortic valves. And if that's confusing you, then I'll just talk about that very quickly. The reason why it confused me is because mitral area sort of makes sense. It's one of the left atrioventricular valves. And the tricuspid area, again, it's on the left-hand side here, but you know that it's more on the right heart, so the right atrioventricular valve. Those sort of make sense. With the pulmonary area and the aortic area, the aortic valve, you might remember, is the left side of the heart, whereas the pulmonary valve is on the right side of the heart, and they're kind of switched here. And the reason why is something Janel mentioned, is that because you've got the sternum in the middle blocking you from auscultating the actual valve itself, you have to suffice with the outflow from each of those valves. So the aortic outflow actually happens sort of more on the right before it loops around as the aortic arch, whereas the pulmonary outflow happens more on the left, which is why they sort of switched around like that. Hopefully that makes a bit of sense. Now with the stethoscope, you can use the bell or the diaphragm, so the small bit or the large flat bit on the front. With the bell, it's low frequency. With the diaphragm, it's high frequency. You really just normally use the diaphragm for everything, except for with the mitral valve, you want to do both just because it can be easier to identify. And sometimes it's difficult if you just use the diaphragm. Some maneuvers that you can use, and again, read your notes because they have really fantastic summary of some of these maneuvers. But the main ones you want to be thinking about in your examination are going to be things that increase either left-sided murmurs or right-sided murmurs for the valves. So expiration, if you ask the patient to breathe out and hold their breath, will accentuate all the left-sided valves. So thinking about the aortic valve and the mitral valve. With inspiration, you're going to be thinking about increasing right-sided murmurs. So that's going to be your pulmonary valve and your tricuspid valve that are going to be increased. So ask them to breathe in and then hold their breath. And if you're stuck, just use the mnemonic RIN LEX, and that should be of some help. So right is inspiration, left is expiration. Okay, and finally, just to end it off, I've skipped percussion because it's not normally done. You will definitely do this in lungs. In that case, it's actually really important. For percussion of the heart, it's only really when you can't auscultate, and for the most part, you will be able to, so I'm not talking about that. For the lower limb, I'm not going to talk about all of this. It's basically just the upper limb stuff, but translated to the lower limb. The main thing that's different is going to be pitting edema. So you want to press on potentially the front part of the lower limb. And like if you notice some sort of edema, and the difference between just regular edema and pitting edema is if you press and you let go, it'll leave a dent. And that's a strong sign that they've got some sort of obviously they've got an edema in their legs, but that could be a sign that they've got right-sided heart failure, potentially secondary to left-sided heart failure. There are some signs for potential peripheral vascular disease, but we're not going to get into that today. Okay, now I know we're at 12 o'clock, and it's okay if you guys need to leave, because ECGs is a very, very long section. There are 4 parts that I've had to split it up into just because of how long it is. Could I just get a couple of messages in the chat of whether you would like me to run through ECGs now, given it's 12 o'clock, or whether you would just like me to record this externally and then upload it as a separate video, because I'm happy to do either. And I know that you guys probably have other stuff on, but if not, I'm more than happy to do it now as well. Does anyone have any preferences?
What we could maybe do is we could maybe go on to the rest of the topics for today.
Yeah.
And then cap it off there and then do ECG. So anyone who wants to stay on can do that. And then that's our recording session for ECG.
Yeah, awesome.
We might
that
do
sounds
that
good.
then.
Yeah. I guess we'll also look at the number of people here. If like there's only like 5 people, then we may just upload this as a separate video. What do you think?
Yeah, I think we should be good.
Okay.
Yeah, so I think we'll just skip over to, I think Kyle's next. And then Marwan, and that should take us through the rest. And then if you guys want to stick around for ECG, sure. Otherwise, we'll just record it and chuck it up. Probably, maybe as a separate video. We'll see how we go.
Yeah, my understanding was Asha wanted it specifically, so hopefully we can do that for her. But yeah, all right, let me get it up. It's always a question. Am I going to crash when I try and present? Always a fun puzzle. All right, here we go. Oh, I'm going to need the host. James, are you still the host? Can you give me screen sharing permission?
Yes, perfect.
Exciting. The power. All right, so I'm just going through developmental differences. It's really brief. It's pretty low yield. And you guys have already really done your HLSD assignment. So medicine of the mind is not super applicable anymore, but it's still worth just getting a holistic view. There's only 2 slides, so we'll go through it quickly. So what is development? So the definition of development from, I think the Center for, I'm forgetting the name of the website, but it's a Monash Center for Developmental Disabilities, and helping people with those disabilities. And their definition is that development is the result of interactions between the child and their environment. Each interaction results in new learning, which results in the development of skills and traits. The right frequency, quality, and intensity of interactions between children and their environment will result in each child reaching their full potential. In terms of developmental disabilities, that really comprises 3 ideas. So an impaired function, so that being cognitive, motor, social, or sensory, that arises from a developmental difference in, I imagine, sorry, I've got a bit of a typo there. Developmental difference in or injury to, sorry, the developing brain. So some sort of difference in the person's developing brain that results in an impaired function. And it's of such a degree that it causes substantial lifelong difficulties in day-to-day living. So those are sort of the criteria that sort of define what a developmental disability is. Developmental anomalies, they are anomaly meaning something that is not necessarily normal or atypical. And they may relate to genetic or anatomical or structural differences. So it may be to do with the genes or with something structurally is slightly different. And injuries to the developmental brain can be related to things like hypoxia, so not enough oxygen getting to the brain during development, things like trauma, toxins, so alcohol, other drugs, metabolic products, and infection as well. So there's lots of ways that the developmental brain can be injured, and that's one of the ways, or I suppose developmental anomalies and injuries to the developmental brain can sort of comprise the causes potentially of developmental disabilities. All right, now I just sort of slapped this together. This is just some examples of sort of the disruptions or opportunities, challenges that we can have in different stages of Erickson's. And I don't even have all of the stages here. So I have the initiative versus guilt stage. I don't actually have an example for right here, but you can sort of you can logically go through these. So for instance, in trust versus mistrust, that's the formation of primary relationships, right? And so if there are instances where there is not necessarily this formation of these primary relationships, then someone can grow up feeling less trustful because they never really had the opportunity to fully form healthy primary relationships, usually with their caregivers or their parents. And so, yeah, a lack of this will lead to mistrust. And that doesn't mean that you're stopped there and you can't move on to the next conflict. But it does sort of mean that that's obviously a very suboptimal outcome in a child's development. And it will probably be something that they will need to address or will need addressing in order to improve the development of someone, even if they are much older and they haven't sort of resolved this basic conflict. That's my general understanding of it. And then so we can think of, yeah, if a lot of this has to do with independence. So if you aren't able to be as independent, for instance, because you have a developmental disability or another sort of disability that occurs during your development, then that may mean that you require more help doing tasks that other children at a similar age would normally be able to start sort of managing on their own. And because of that, that can sort of result in the less optimal outcomes for each of these conflicts. So it's something that definitely needs to be addressed in a child's development, especially if they have a disability, finding other ways that they can still be independent, obviously, while still providing support where needed. You need to sort of foster independence in the realms that are safe and healthy for individuals' development. That's the general idea. You can sort of logically go, okay, well, if you have a cognitive or motor impairment, then that's going to make it more challenging to sort of reach this industry aspect, the mastery of new skills in your early school age. And so that may lead to feelings of inferiority because of this physical aspect or this cognitive aspect where you find it more challenging to develop or to master new skills. And so evidently you'd need to take that into consideration. And that's really, I think, where we're at in this sort of level of learning is being aware and sort of thinking about how certain things may impact relating to these Erickson stages. Not super high yield, but obviously still important and very important to be considerate in your general life. And I imagine that we will come across these things in our clinical experience. So thank you. All right, that's it. I think we're on to improving performance. Hep, who did that?
That's my one, I think.
Amon?
Yeah,
take it away.
That's me. Thank you. Just share screen. Yeah, so a little bit of Hep. Today we are going to talk about mindfulness. So to start with, we will talk about mindful practice, which is a practice to get to the state to be mindful. It's not about relaxation, but it's more about having the full attention, and it's essential to enable self monitoring, which can provide an early recognition of cognitive biases so that we can avoid technical errors, especially for us as future doctors. Awareness of emotional reactions, facilitation of self-correction, and development of therapeutic relationships. And mindfulness reduces motivation but increases performance. How is that done? Motivation is defined by two criteria: arousal and future focus. So mindfulness reduces arousal as well as future focus. So this will reduce motivation. However, it also improves executive function of the prefrontal cortex and improve working memory, which altogether cause an increase in performance. Then we have Dodson stress performance curve that we can see here. Shows the typical relationship between stress and performance, where point A, where we are too relaxed, there is no stress at all, so we basically do nothing. And then as the stress increases, our performance increases until an optimal point where it will be the highest. And then after this point, we're actually getting more stress and we will be too stressed, which reduces our performance until we will have the highest stress and cause us to make the poor performance. And in this other curve here, it shows the relationship between performance and stress with the intervention of neurofeedback, where neurofeedback can adjust arousal state towards lower stress and cause us to be in flow mode or state. So what this graph suggests is that when we have neurofeedback and when we are too relaxed or have no stress at all, we can either do nothing and have no performance at all, or our poorest performance, or we will be at our highest performance. And here are the characteristics of zone or flow state or mode, where we have deep but effortless concentration on the process, sense of self-control and absence of self-consciousness, or ego, enjoyment, relaxation, confidence, and freedom, focus on the goal, although not anxious about it. So we do focus on the outcomes, but we are not worried about it, and we are in the present movement. And finally, we have our highest performance. Then we have something called attention deficit trait, where when we have to deal with too much input, and this causes black and white thinking, where there is no gray area or no thinking between black and white. We have difficulty of staying organized, priorities, and managing time, and we do feel a constant low level and guilt. However, this can be controlled by making time for us, a portion of our day just for ourselves, taking enough sleep, having a good healthy diet, get some exercises, and breaking down big tasks into smaller ones. And then we have multitasking. There are two types of multitasking: simple multitasking, when each task is given the same priority. So walk and talk, we can call them simple tasks. We can combine between these two. However, in complex multitasking, we have two complex tasks that both demand cognition, and it's basically impossible to do the two tasks together at the same time, where you need to switch between these tasks to get it done. Otherwise, you have poorest performance. So why people do multitasking? Because to get more done and to have full life. However, it does have consequences. It will reduce performance, reduce ability to set relevant from irrelevant, impaired memory, impaired communication, empathy, increased stress response, fatigue, and prefrontal cortex, reduce creativity, and finally increase errors. Then we have attentional blink, which is a lag time. It's about half second when switching to attention. So we switch attention when we do complex multitasking, and it increased by stress, which causes limitations in information processing, the time gap in being able to identify and consolidate stimulus in memory, and finally, we can take more than half a second to be fully free mind to do or to have a second stimulus. It will be vulnerable to distractor interference. And this can be reduced with 3 months of mindfulness-based attentional training. Also, we have something called the default brain, or the default state, where our mind will be inattentive, distracted, and daydreaming. And it has been noticed that the areas that are active in default mode, we can see them in blue here, are very similar to the areas affected by Alzheimer's disease, which you can see in the red color here. And this is associated with stress, anxiety, depression, schizophrenia, autism, Alzheimer's, dementia, criminal recidivism, and reduced performance. And this can be deactivated when actually paying attention, which mindfulness or mindful practice will help to do. Finally, we have inattentional blindness, which is the failure to notice fully visible but unexpected object because our attention was engaged in another task. So we weren't looking for this unexpected object. For example, when you took something in particular, for example, car, and it's easy to miss other irrelevant but unexpected things like cyclists, because we simply weren't looking for it. And this can be avoided by just looking generally at the bigger picture first, and then look for the particular thing that we are interested in. And that's it for today. Thank you so much.